diffusion-weighted imaging. This technique allowed us to see new ischemic lesions without the need for a prior exam. Talk a little bit about the appearance of stroke on those images we acquire, the concept of silent stroke, and after a little detour to our field in neuroradiology, I will go and try to answer the question of the clinical relevance in the cardiac field. Now, DWI in a nutshell is easy to explain on the surface. If a cell swells, you see it here in the middle, the intercellular room is diminished, and there the cells move usually on the left more faster, the water protons. So the diffusion is restricted, and this you can see on the right as an increase in signal intensity on the DWI lesions. And you can actually measure those changes on the ADC maps, and they are black, and this shows the restricted diffusion. It's important to know, and some studies are really confusing the results. They measured these lesions too long. They stay only 7 days negative. After that, it's hard to say if it's a new lesion or not. Larger lesions you might see longer. Smaller lesions, especially if you do a measurement immediately after the event, might be reversible. Of course, ADC changes are not unique for ischemia. They might as well happen in inflammation. However, overall, the ischemia depicted on diffusion-weighted images is usually this area, which is the core of the infarct later, and the penumbra is the area of the perfusion deficit. So these lesions, with other words, stay. Now there are different lesion subtypes we can see on brain images. Not all are embolic, it's important to know. And there are the majority of lesions probably we see in the elderly populations are small vessel disease. So these are caused by a disease of the perforating arteries which enter the brain, and at some point they are of course acute, and they might make new lesions which are visible on DWI images. And that's very nice of DWI nowadays, that in those elderly patients with a lot of lesions, we then can distinguish and attribute a new lesion to a clinical syndrome. This was before sometimes not possible. Hemodynamic stroke, on the other hand, is a rare event. Here we have a compromise of the inflow into the brain. And there are certain areas, the watershed or border zone areas, so these are the borders between the territories of the cerebral arteries, and they are especially prone to undergo to infarct if there's not enough blood flow. And this you might see as well on DWI lesions, And you see here nicely all these small infarcts. Now, sometimes it's hard to tell if a lesion, which you see, is a hemodynamic infarct or if it's an embolic infarct. Now, what helps here, of course, is an assessment of the brain vasculature and the cervical vessels. That's a patient of ours we treated recently. We didn't know exactly how he was nourishing his brain. All the vessels were occluded, leading to the brain, except the right internal carotid artery. This had a high-grade stenosis, and it's then very likely that these infarcts we see here are watershed infarcts. And we put a stent in here, and the patient improved, indicating the hemodynamic compromise. Now we come to those strokes which are of most interest to us in our setting, and these are embolic strokes, and they might affect a whole territory. It's a large territorial infarct, for example, shown here in the posterior cerebral artery territory. You see the occlusion of that artery, or multiple territories might be affected. And if we see this here, of course, we say there is probably a cardiac origin of the stroke. Now, evidently, if we think about diffusion-weighted images, we think about acute stroke and treatment options and so on. However, the silent brain infarcts are much more common, 5 times more than overt stroke. And in specific populations, like in patients with cardiovascular disease, the incidence rate is up to well over 50%. And this means we have a lot of old patients with silent brain infarcts previously. And this is associated with cognitive decline and a big increased risk of dementia. So the main question to answer is, do these DWI lesions lead to cognitive decline in the end? And this is hard to answer. So first, the detour, how often are they? In neuroradiology, we looked very early on the occurrence of those lesions. And to sum it up, the new lesions occurred in about 20% of all cerebral angiography procedures or interventions on average. These were small studies, and what you see here on the left is the measurement, During an injection in a carotid artery with ultrasound, you can see that a shower of emboli, and here you see single events. Now, 1 out of 5 patients with cerebral angiography has a new DWI lesion. This was as well a motivation to look in a more specific way in the ICSS study in that we participated, to look how many of those patients develop new lesions, and this was astonishingly high. Unfortunately, our stenting group did much worse, despite no big difference between the two groups in the clinical outcome, with 50% having new DWI lesions, and only 17 in the surgical arm. Now, you might say, oh, this is very dangerous, carotid stenting from that by itself. However, another group used this large study and looked at the neuropsychological outcome. And this was a prospective study with a lot of patients, and I guess the neuropsychological assessment was very well done, and they did not find a statistically significant difference between those two groups. Now, what is it in cardiac surgery? The motivation to investigate this is clearly that focal neurological deficits are rare after cardiac surgery. However, we have heard about this previously. Postoperative cognitive dysfunction is common, and there's an assumption that it might lead to chronic dementia. Now, there are a lot of studies that counted the DWI dots, and they found on average that about 30% of patients undergoing cardiac surgery had DWI lesions. That's a very nice review, I think, previously published by Sun, who summarized those studies. However, very few of those studies really looked at the neuropsychological outcome over time, and I show you here two. It's a small study, 39 patients, and they underwent cardiac bypass surgery. And new ischemic lesions were here in 51% of the patients. However, long-term cognition was only predicted by the early cognitive decline, but not by the new DWI lesions which were seen. And another study, a little larger, most recently published, 160 patients, again, bypass surgery. They had only 15% DWI lesions. You see the big span. Again, DWI didn't help to predict the cognitive decline. What about cardiac intervention? Their new DWI lesions are seen in 2 to 15% on average. I show you one most recent study, which I think is nice because it compared surgery and the interventional arm, and good for a cardiologist. The rate of new DWI lesions was much lower. In the interventional group, it was 3% versus 18% in the surgical group. However, this study showed in a way a different result. One of those studies who showed that there might be an association between DWI lesions and the cognitive outcome. You see here, those patients with new lesions performed worse in some areas of neuropsychological techniques. So what's the story now? All of that, DWI lesions are relatively common. From what I read, there's no convincing association between new silent lesions and cognitive decline. Now, would it be meaningful to say we now need larger prospective studies? I don't think so. It wouldn't be of help for individual patients. I think what should be done is a more personalized assessment and analyzing the pre-interventional cerebral lesion pattern. And we have now in neuroradiology the possibility to segment the brain and the lesions in the brain very fast in a computerized way. And you see here 3 patients with different lesion load silent infarcts, not severe, here severe, all these infarcts. And now this is a lot of data, but you can do now define numbers to patterns. It's a mathematical method developed or based on methods developed by Zernike. You can assign clusters and assign them to numbers and then correlate them with the clinical outcome. That means you could have in the end, maybe, that's an idea, a look at the MR image and you say this patient, if he has only slightly more DWI lesions, he might really suffer from cognitive decline. There might be a tipping point which we can't yet with all our neuropsychological technique and so on not recognize. Now this was all about cognition. One last remark. You have really to avoid, of course, embolic infarcts. They can have, even if they are small, terrible effects. That's the case from 2 weeks ago in the cath lab, a patient undergoing an investigation due to coronary heart disease. And during coronary angiography, had a severe neurological deficit. We thought it's a large vessel occlusion. We went in and made a 4-vessel cerebral angiography. We didn't see nothing. And in MR, you see only these few lesions, but in strategically important lesions, areas, and explaining the clinic perfectly. In other areas, you shouldn't waste time to perform DWI images. If you have a vessel occlusion and you see it in the cath lab, it's important that we work together and that we remove the clot and don't make images. And this image I chose, it's as well from most recently during cardiology procedure, and it shows an occlusion in the M2 segment, so quite distally, and this flow retriever is quite fast, far out there. We can get very far, and we removed it, and this was the good thing to do. I'd like to thank my coworkers for the discussion and you for your staying here. Thank you very much.